Welcome. Thank you all for dialing in for this congressional briefing on reimbursement parity, how sex-based valuations harm patients and increase costs. We have an amazing panel of experts today. We are excited to share information and updates. We've actually been working very hard on this issue over the past year or so. We had a Capitol Hill briefing in person last year at this time. We've done several meetings with both this current administration, the previous administration, and several folks on Capitol Hill. And what we're finding is that once people understand this gap, they're very interested in finding ways to close it. So a little housekeeping, wanted to make sure you know this is recorded and we will send this to all who registered. If you have questions, put them in the Q&A box. We hope to answer them, but if we can't, we'll try and do a follow-up email. And then before we dive into our experts today, we have some special opening remarks from two members of Congress. First, Congresswoman Lori Trahan, and then Congressman Juan Cismani.
Thank you to everyone joining today for this critical discussion on reimbursement parity and its direct impact on women's health. For more than 2 decades, the healthcare system has consistently undervalued services tied to women's health. Across more than 100 billing codes, reimbursements average 30% lower, with some disparities reaching as high as 150%. These gaps are not abstract. They send a clear signal about whose care is prioritized and whose isn't. When women's health services are undervalued, the consequences are immediate and tangible. Providers face financial disincentives to offer these services, leading to fewer available specialists, reduced access, and longer wait times. Patients experience delays in screenings, diagnoses, and treatment for conditions that they require timely care. In many cases, what could have been addressed early becomes more severe, more invasive, and more costly. This issue goes beyond economics. It speaks directly to health equity and the quality of patient outcomes. Women shouldn't have to navigate a system where the care they need is systematically devalued. These disparities contribute to worse health outcomes and reinforce gaps that should not exist in our country in the year 2026. Addressing reimbursement parity is essential to strengthening women's health. In fact, I would argue we cannot make enough progress without it. But to get there, we need recognition of the full value of these services, support for the providers who deliver them, and a commitment to ensuring patients receive timely, high-quality care. I'm grateful to the experts here today for bringing attention to this issue and for helping drive solutions that put women's health where it belongs, at the center of our healthcare priorities.
Hello, this is Congressman Juan Cismani. I'm sorry I couldn't be there in person with you, but I do appreciate the opportunity to thank you for taking the time to focus on an issue that doesn't get nearly enough attention. For far too long, we've seen real disparities in how certain medical procedures are reimbursed, especially those that primarily affect women. In many cases, those procedures receive 30% lower reimbursement, and the gap has been there for years. This isn't just about numbers. This is about real consequences. When care is undervalued, and it can mean fewer providers, it can mean longer wait times and less access for patients. And when care is delayed, small issues can turn into much more serious issues and more expensive problems as well. That impacts women's health all across. Now, as a dad of 3 girls myself, husband to my wife, Laura, brother to 2 sisters, and of course, with my mom who lives near us, this is personal for me, and it's also personal for all of us. And at the end of the day, this is about getting it right for patients. It's about making sure women have access and options to the care that they need, when they need it, and that providers are supported so that they can deliver the best possible care, all while driving down costs and expediting actions. In Congress, and as an appropriator, the only appropriator in Arizona, Republican or Democrat, House or Senate, I'm the only appropriator in Arizona. So I am committed to advocating and advancing common sense solutions, such as increasing funding for the Office of Research on Women's Health to nearly $100 million more. This will help address the disparities, improve on and develop new outcomes and strengthen our healthcare system for the long run and for the future. So thank you for bringing attention to this important issue. What I just described is just one step to what we've done, but there's a lot more to do. And I join you on these issues and on these concerns as well. By advancing policies that ensure fair reimbursement and deliver better outcomes for women, which has been overlooked for many, many years, this can all be part of the solution. And I join you as well in bringing attention to this issue and to these concerns. Thank you for your work. Thank you for your advocacy. I stand with you, and we'll keep on working together to get this done. Thank you.
Thank you so much for those remarks. So helpful to have bipartisan support in these efforts. The speakers that we have today are up on the screen, and we will go in this order. So we will first hear from Minna Lee, who is a content creator and advocate. We will then hear from Dr. Louise King, who is a professor as well as a doctor and affiliated with Harvard Medical School, Mass General, Brigham, Boston University, and ACOG Ethics Committee. We will then hear from Dr. Jocelyn Fitzgerald, who is also a professor and a surgeon at Magee-Womens Hospital at the University of Pittsburgh Medical Center. And then we will have Dr. Teni Brown, who is a surgeon at the Northwestern University Feinberg School of Medicine. And then we have Dr. Asha McClurg, who is a professor and surgeon at the University of North Carolina, Chapel Hill. And then we have Christopher Robertson, who is a professor at the Boston University in both the law and the public health programs. So amazing experts that we have today. And real quick, today's briefing and a lot of this advocacy effort on this issue is coordinated by Women's Health Advocates and the Surgical Parity Project. These two organizations are working really hard to close gaps in reimbursement. And Women's Health Advocates in particular is addressing all of women's health head to toe over the lifespan. So this is one of many issues that we address. And we are looking forward to working with you to advance the health of women through better policies and funding. So with that, I would love to pass it to our first speaker. Real quick, this is the agenda that we'll be covering today. Sorry about that. We will cover what happens when we don't know the value of women's health, which is what Minna is going to cover, the architecture of reimbursement, the proof of devaluation, the impacts of devaluation, how undervaluation affects patients, both access and quality, and then the fix, the legislative fix, the administrative fix that we want to close out with you today. So with that, now we will turn it over to our first speaker, Minna.
Hi, my name is Minna, and I'm here to share my experience with endometriosis and obtaining surgery. It took me almost 3 years from getting the confirmation from an endo specialist that I was a surgical candidate until I was able to get the excision laparoscopic surgery with another specialist, solely because of insurance obstacles. There are already very few endo excision specialist surgeons out there that can do a thorough job with the full understanding that endometriosis can grow on organs other than reproductive organs like the appendix, bowel, lungs, and even the brain. And there are even fewer surgeons that accept insurance. And with those surgeons that accept insurance, there's often a months, if not years long waiting list, even for a consult. To give some context, my insurance that I was only able to obtain because of my husband's employer-provided insurance was not in network with my original endo specialist doctor. The surgeon's fee out of pocket was $20,000, and that was not including hospital fees, which I could not afford. I applied for an appeal for an out-of-network exception and was denied, with them stating lack of evidence of diagnosis. The irony being there's no way to definitively confirm an endometriosis diagnosis without a biopsy of lesions, which can only be obtained through laparoscopic surgery. My insurance company then suggested that I had to first try surgery with in-network doctors, all of whom in my area only performed ablation. Ablation surgery can actually worsen endo significantly by creating more inflammation with lesions and does not improve the condition for most people. My insurance company wanted me to try a surgical approach that endo specialists mostly all do not perform. They wanted me to pursue near certain failure before reconsidering and now not promising an exception for my appeal. I moved to California 2 years later for work and was able to find one of the few surgeons that accepted my insurance, which is fairly good insurance, by the way. but I was 96th on the wait list for a consult appointment and was only able to accelerate to getting the surgical consult when I sent my previous imaging and medical notes from my previous specialist, who confirmed that I was definitely a candidate for surgery. My surgeon was wonderful, and I thank my lucky stars that I could get surgery with him because it improved my condition a lot. But fast forward to today, he is now no longer accepting insurance and has moved to a private practice like many of the top endometriosis, minimally invasive gynecological surgeons because of this reimbursement disparity not adequately addressing and incentivizing providers for complex procedures like this. My endometriosis worsened significantly over the years between my initial loose diagnosis with the specialist until the nearly 3 years I had to wait until I had surgery. Before my endometriosis became symptomatic, I worked 3 different jobs in pursuit of building out my career. But after my endometriosis symptoms and pain began, I had to give up 2 of my jobs that required me to be in person because this condition is so unpredictable in its pain and symptoms. I've had to shape my career and ability to provide for my family with this disabling and debilitating condition in mind. And I've had to sacrifice many opportunities over the years for further advancement and better pay because of my limited physical abilities. Before my surgery, my day-to-day function was extremely tough. Everything from full body pain, which people don't know that endo often causes pain in areas outside of your pelvis, especially my extremities, bathroom urgency, pelvic floor dysfunction, nausea, brain fog, extreme fatigue, and digestion issues. It's like you have a limited battery for everything and have to pick and choose what you're able to do and say goodbye to the rest. At my worst leading up to my surgery, I would probably have about 2 to 3 good days out of the 30 days in a month. And I wasn't even as disabled as many other endo patients that I know. And to put the pain in perspective, I'm a former competitive athlete who was trained and performed on sprained and broken joints. And other friends of mine with endo have given birth unmedicated and say that unmedicated birth was not as bad or similar to endo pain and cramps. Make no mistake, this condition is a disability. And considering that excision surgery is one of the true treatments for endometriosis, the barriers to accessing surgery must be lowered in every way possible. This should never be considered an elective surgery, because imagine having your leg bones be broken in an accident and then the surgery to repair those breaks were to be called elective. To find out that surgeries involving women's gynecological conditions are evaluated less to insurance and hospitals than a surgery for someone with male anatomy is appalling. No wonder it decreases the incentive for surgeons and hospitals to be able to provide this care that's often also far more complex and challenging to treat, considering there's less research funding allocated to conditions like endometriosis. So who pays? We do, us patients, both in our in and out-of-pocket costs, our quality of life, quality of care, and possibility of saving wasted times, personal goals like family planning, and even economic contribution if we're viewing it from that perspective. This must change. Thank you.
Thank you so much for that. We will keep moving forward to the next slide. Dr. Louise King.
Thank you so much. It was very inspiring to hear our congressional representatives backing all of these efforts. And thank you so much to Minna Jamison for sharing her story. I'm a minimally invasive gyne surgeon who specializes in endometriosis. We accept all insurances, just for your information, but it does make things difficult. And that's also true of a variety of conditions, including with fibroids that are under reimbursed, and a variety of conditions that could be treated related to pain, infertility, and ovarian cysts, etc. All of which are underfunded in our systems. I'm going to talk to you a little bit about why that might be, just in terms of the way the system is currently set up. Next slide, please. So there are 4 million surgeries performed every year, and most of them are, not all, but most are underfunded. Next slide. This is the framework and the bias that ensues within the architecture of our reimbursement. We're going to go through this in detail, but generally speaking, we have a system of reimbursement defined by the CMS and the AMA Commission to set the relative value units, which we'll refer to as the RUC from here forward. And because of the way that system comes about and assesses the value of certain care, we end up with undervaluation of women's care. Next slide, please. So pay is then resulting in less valuation to a variety of conditions, leading to what we've defined here as pain, but in a much broader sense, not only the pain that patients like Minna experience, but also just pain within the system and not achieving the best outcomes. Next slide, please. Our GYN patients thereafter suffer worse outcomes in relation to this. We all work within a fee-for-service payment model. And so anytime that any of us provide any kind of care, it incentivizes us to do the service, not necessarily the outcome itself. And we could talk about a variety of ways we could assess changes in our particular plans and ways of which we reimburse care to set value as and better outcomes as our final goal. But at the moment, we prioritize how many procedures you do. And then once you've done those procedures, you send a bill for that to either the insurer or CMS, and then you are then reimbursed. Next slide, please. So what is this relative value unit that is underlying setting the amount of money that pays for each thing that we do? Every single procedure that we do has a billing code, and the Centers for Medicare and Medicaid Services, CMS, assigns each code a value known as a relative value unit. This all began here at my institution at Harvard University, specifically the School of Public Health in the 1980s, when they created a study of the relative valuations of things that different people were doing, different clinicians were doing. They almost entirely ignored obstetrics and gynecology and were much more focused on male-dominated procedures, specifically cardiology and orthopedics, urology. In 1992, CMS adopted this relative valuation system. Next slide. Within the relative value unit is time, and that's the predominant thing that governs how much value is assigned. Also, some component of skill, and then a little bit allocated to the costs of running the medical practice, the actual things you're using to do the thing you're doing, malpractice insurance, a little bit of consideration. There's then a geographic adjustment that's applied and a conversion factor that's determined yearly, and that's the payment rate. Next slide. Who decides what these RVUs are going to be? They started with that Harvard School of Public Health study, but thereafter it's been the RUC through the AMA, a committee of different representatives from national professional organizations that come together in a meeting and a variety of work that goes on behind those meetings to create these relative value units. Next slide. There's an update committee. Again, I've referred to them as the RUC throughout. Gynecologic surgery is the only specialty of the 32 votes. It's the only subspecialty that's surgically based that does not get its own vote, with a couple of very minor exceptions. We share the vote that we have and the ability we have to create change with obstetrics. And so through ACOG and ACOG's one vote, we are sharing the vote with a lot of concerns and issues that we're raising around obstetrics. And for a variety of very important reasons, the American College of OB/GYN has been much more focused on ensuring parity in valuation for obstetrics, in large part because of the maternal mortality crisis and a variety of other issues around ensuring good care in obstetrics. And so there's less attention paid to surgical considerations within gynecology and the way that we could create change in that space. Importantly, 85% of OB/GYN residents, people going into our discipline, are women, and 65% of currently practicing OB/GYNs are females, and there are only 12.5% of the RUC seats are held by women. Next slide. There's also a budget neutrality clause. So in any given year, the RUC is considering a very defined pie of money that they can make changes to and move things around within. And so again, when you think about how the American College of OB/GYN is marshaling its influence with this one vote, they're thinking about this very finite amount of money. If they argue for increased funding within gynecology, you can imagine there might be less increased funding for obstetrics. And so when that is part of their consideration, and rightly so. There have been exceptions made to this budget neutrality clause to correct problems within valuation in the past, but never for women's health. Next slide, please. CMS almost always accepts all of the RUC's recommendations. So the recommendations coming from professional organizations to the RUC through ACOG, for example, to the AMA, then goes to CMS, and CMS accepts approximately 90 or to 95% of those recommendations. Medicare then sets the standard for commercial insurers. So many of us, myself included, don't derive my medical care through Medicare, but through my commercial insurer. But those reimbursements that are set around the care that I receive are also determined by these RVU units. So the reimbursement discrimination that exists within our government system that we're going to describe in great detail to you today expands not only into Medicare and Medicaid reimbursement, but also into private reimbursement. Next slide, please. There is no transparency. I actually have sat on the committee that informs the RUC through ACOG. And even within that space, I did not receive transparency around some of the questions that were raised about reimbursements set by the RUC. We've also requested information that we think would be important for us to understand some of the details around this. And we've been informed that there is no ability to request records about deliberations within the RUC through FOIA or FACA. Next slide, please. So surgeries, now I've explained to you how these surgeries are reimbursed on this fee-for-service basis, how CMS relies on the AMA Commission to set the RUC to set these RVUs for up to 12,000 different procedures in women's health, and how private insurers follow these regulations around RVUs. Next slide. From here, we're going to talk about bias. There is significant bias in how the AMA sets these numbers, and male surgeons are underrepresented in gynecology, but then provide biased self-serving estimates that influence and uptick the amount of reimbursements that are given, for example, in urology. Next slide, please. So typically, I mentioned earlier that the biggest player in setting RVUs is time. And the way that the AMA sets this time component of RVUs is based on survey methodology. This survey methodology, surveys that are sent out to physicians and surgeons, have exceptionally low response rates, low total number of responses, and a vast range in responses, and they don't really conform to the realities that exist. Next slide. What we've noted in a variety of studies is there's significant self-reporting bias, and specifically in some of the highest paid surgical disciplines. So frequently we can compare gynecology to urology because they have very similar procedures, and we can anatomically link them and compare them and see these disparities. And we know that these disparities are driven in part by this self-reporting bias, where urologists are reporting that they're spending more time on things than they are actually spending on them. Next slide, please. It's important as well to recognize, again, something I mentioned earlier, this gender representation by specialty. OB-GYN is a discipline where we treat women predominantly, and we are women who are in this discipline predominantly, which is very different than in many other specialties that are surgically driven. Next slide. And there have been many critiques of the RUC over many, many years. You can keep clicking on slides and you'll see a bunch of them pop up if you just keep clicking. We've been complaining about this and highlighting it for so long, so it's so heartening to see our representatives helping us out here and seeing patient advocates coming forward and telling their stories. There's so much room here for improvement and to improve the lives of our patients. Next slide. I think we can move forward to economics, and I think we'll be at Dr. Fitzgerald's presentation. So let's switch over to her.
Hello, everybody. Thank you so much for your time, and to the other speakers. This is such an important topic, and And I hope that you will see that when women's bodies are devalued in the healthcare system, it has many downstream effects that get passed off and lead to worse outcomes. So we can go to the next slide. I am a urogynecologist, which is a specialty type of OBGYN or urology trained surgeon. I trained in OBGYN, but it does give me particular insight into the differences between female urinary tract procedures that like prolapse or incontinence compared to male urinary tract procedures. I work very closely with urologists. And so when we're looking to sort of really drive home the point that this phenomenon we feel every day in our hospitals in terms of our patients being physically worth less money to the healthcare system, the best apples to apples comparison we have is gynecologic surgery and urologic surgery in men. So we've found, myself, Dr. King, and some other of our colleagues, that urologists perform male procedures are worth on average 30% more than equivalent female procedures. So I'm talking like a biopsy on the vagina versus a biopsy on a penis. Those things are worth 30 to sometimes 50% more when they're done on men. And in particular, if it's a urinary tract procedure, something I would do on a female patient, it can be up to 49%, pretty close to 50% more. And it becomes even worse when you take into account insurer payment rates are typically different depending on what specialty you trained in. So there are some surgeries I do as a gynecologist, trained urogynecologist, that a urology trained urogynecologist would do the exact same surgery. They get paid more to do it because they are a urologist. So it perpetuates on so many levels this enormous disparity for our patients. Next slide. This is the paper. If you're interested in taking a look, we thought we were pretty clever with the title, but it really drives home this point that this is not only happening on a case-by-case basis, RVUs compared to RVUs for equivalent procedures, male, female. It also goes into more details about how when you bill a hospital for facility fees, which is in large part how insurance companies recoup and pay hospitals, that the hospitals are getting significantly more reimbursement to take care of male patients. Next slide. Here is just a simple schematic, again, to really drive this point home. If you see here a female procedure as a standard price point, male procedures 130% more, or 30% more at 130%, and then male procedures on the urinary tract in particular, male urethras, male urinary issues are 50% more. Next slide. This is just sort of an example of some things from the study. We don't have to belabor this, but I do think it kind of gets people sort of really interested when you know it's not always said in sort of like polite conversation to talk about genitalia and sort of genital-based medicine. But you can see here that the biopsy analogy I gave is very similar to like the biopsy of a prostate versus a biopsy of an endometrium, which is how we discover prostate cancer versus endometrial cancer. Looking at the biopsy of a prostate and a biopsy of an endometrium, which is an internal organ biopsy, very, very comparable in terms of pain, in terms of setup, in terms of cost to an office. The biopsy of the prostate reimburses 10 times as much, which is really a huge problem and leads to delays in diagnosis of endometrial cancer, which is on the rise in this country. Next slide. This is an example. A lot of, I wouldn't say naysayers, but a lot of people love sort of in the healthcare economic space like to say that this problem has gotten better over time, and our study shows that it absolutely has not. In the last 20 years, it has stayed quite stable, and if anything, has gotten worse in terms of reimbursement for female-based procedures. Next slide. Here are just some examples to really also drive this point home. I know that a lot of you watching may live in the Washington, D.C. area. I did my training there in urogynecology at Georgetown and frequently operated a very nice surgery center called the Lafayette Surgery Center, which is in Foggy Bottom. And after COVID, after I had finished my training, that surgery center actually discontinued gynecologic surgical services because of how much less money those services garnered for the institution than procedures done in other specialties. So just this slide is to kind of explain why something like that might happen. So I'm a urogynecologist. I spent 7 years in my surgical training, and one of my surgeries, probably the most complicated surgery I do, takes 3 to 4 hours of time and reimburses Dr. King explained RVUs, 17 RVUs. So it's an arbitrary sort of system, but we'll just say the relative value of that surgery, which is to do a vaginal prolapse reconstruction, is 17. If you then look down, we'll do a couple other examples. An endometriosis excision, like what Dr. King does all day, can be an incredibly complex surgery. Next door to my operating room yesterday, one of my minimally invasive gynecologic surgeon colleagues was doing a stage 4 endometriosis excision. I looked over through the window, and she had been operating for almost 7 hours. And an endometriosis, and she's a specialist, she does this every day, she's the best at what she does, only recoups 12 RVUs for that surgery. Look down here at an orthopedic surgery, a shoulder arthroscopy, which takes about 30 minutes to an hour at most, and recoups almost 16 RVUs. So orthopedic surgeons are doing a lot of procedures that are worth more than these 3, 4, 5, 6 hour surgeries that we do, and they're doing them in 30 minutes. So you can see how these institutions that pay for surgery and support our patients would be very quick to discontinue women's surgical services in lieu of these other things. Next slide. I kind of already just gave some examples, so I won't belabor this, but endometriosis is such a prime example of a disease that is being driven out into a cash-based practice because hospitals that aren't necessarily part of large institutions that can supplement the loss that the operating rooms experience providing endometriosis surgical care are simply no longer able to prioritize it or provide it. And so patients are paying the price with mortgaging their homes, credit card debt, etc. And there's only one billing code for this wildly complex surgical disease that is just as common as diabetes in this country. Next slide. We're going to show this slide a couple times, but I think it is worth saying that in addition to there being discrimination because our patients are majority female, there's also a significant correlate that Dr. King alluded to in terms of the percentage of women that are in that surgical field. So if you click a couple more times, you'll see that as a function of how many women are in the field of urology, very few, their annual compensation, and importantly, reimbursement, their value to the hospital. Hospitals are very happy to hire urologists because urologists make a lot of money for the hospital. Down here in the far right corner, in terms of percentage of female share, you see half in terms of reimbursement and recouping costs that gynecologic surgeons make for hospitals. So if a hospital has a choice in terms of hiring a urologist or a gynecologic surgeon, you can see kind of where their energy and investment might go. So I'll stop there and hand it over to my colleague, Dr. Brown.
Hello, good morning. Thank you for joining us. First of all, everything that my colleagues said, I'm just going to build on that. The notion that gynecologic surgery is not valuable, I hope you guys have realized that this has profound or could have profound consequences downstream at multiple levels. And so I'm going to start at the hospital level. Next slide. We can go to the next slide. Perfect. So hospital systems don't allocate resources randomly. We all know that. They use a mix of financial performance, strategic priorities, demand, mission alignment to decide what service lines are going to get funding, staffing, and growth investment. And we know that finances is not the only thing, like I said, but typically there are different metrics, including the contribution margins, operating margins, payer mix, and RVUs, like we referenced earlier. And what this means in reality is that high margin service lines often get more resources in the form of capital investments, for example. So based on what my colleagues have shared, when insurance reimburse gyne procedures at much lower rates, hospital systems are often disincentivized to prioritize gynecologic surgery. And what you end up seeing is an inevitable global disinvestment in gynecologic service lines. And what this looks like is leadership allocating resources away from gynecologic surgery towards higher margin lines. And this translates to less operating time. Maybe the capital budget request for new robots was denied, so less equipment, less staffing, and that's both surgical and anesthesia. And most hospital systems don't walk in saying, hey, we are going to discontinue your gynecologic service line. But the downstream consequences of that initial disinvestment eventually leads to closures of multiple of gynecologic service lines. And we've seen that across the country over the past 5 years. And this is a result of, when you take away resources, you can no longer support the same surgical volume. People will start referring elsewhere. I'm not going to touch too much on the wait times that patients will start to see. My colleagues will have referenced that, and we'll talk more about that. And eventually, it becomes this internal narrative that, this service line is really it's not worth it. And we're seeing that across the country where several hospitals are closing their gynecologic service lines. Next slide. Dr. Fitzgerald put this slide up, and I'm just going to touch on this for a moment. There are also consequences at the physician level. Again, not when you devalue the services that a specialty provides, it impacts the reimbursement for the individuals that choose to practice that specialty. So I'm going to orient you to this graph. On the x-axis is the percentage of females in that specialty, so women. And on the y-axis is the annual compensation. So I also am a urogynecologist like Dr. Fitzgerald. And so we fall in the obstetrics and gynecologic surgery side of this graph. So it's the far right. And our urology colleagues are high up on the left part of the graph, as you see there. There's a huge disparity in compensation. And people love to say, oh, physicians make a lot of money. Why should we care about this? Well, it is really important for the following reasons. Next slide. Our medical students, for example, are watching this. So the average medical student incurs about a $200,000 debt burden when they choose to pursue a specialty in medicine. People have to think about, for example, how they're going to live, but also how they're going to pay back their loans. And if you look at that, that compensation graph that we just showed, it does drive the decision-making for a lot of our trainees in terms of what specialty they're going to pursue. And ultimately, this can impact the interest in our field, and we do see that. Dr. King also talked about the financial incentive for obstetric services. For those who choose to join OBGYN and practice in this specialty, they often have to make a decision of where you're going to spend your time. You're both trained in gynecologic surgery and obstetrics. But when the reimbursement favors obstetric services, we see a shift and a trend in individuals choosing to focus more on obstetric practice. And that leads to lower volume gynecologic surgeons, because if you're not doing the gynecologic surgeries over time, your skills are going to decay, and that has profound impacts and consequences for our patients, which our colleague will talk about later. Next. And we can go through that. I do want to end with this slide because I thought this study was pretty interesting. I go back to that compensation graph that was shown with OBGYNs making way less money, and actually they're the lowest paid surgeons, surgical specialty. And then you see the data at the hospital level. So this table here is from a study of one single public university and one institution. And it listed out all the surgical volume for each service line, their operating room time, the duration of anesthesia, surgery, just to give a sense of how people were spending their time. And I'm just going to highlight that the gynecologic service line, which they did lump with breast, and that's fairly common. That's also how we break this down at my institution as well, at the women's hospital. The gynecology service line was the fourth most productive service line in this particular hospital system. And you can look at the number of surgeries that were performed. And their surgical time was actually about half the amount of time that the other service lines spent on their surgery. So we're really, really efficient surgeons. And I put this on here to say, can you imagine if this service line was valued and reimbursed at the same level that orthopedic surgery is reimbursed? We could make the hospital system so much more money. And I'll end with that.
Hi, everyone. I'm Asha McClurg. Thank you so much for taking the time to join us today. I'm a minimally invasive surgeon. I specialize in complex GYN surgery, excision of endometriosis, and surgical treatment for fibroids. So my wonderful colleagues have talked to you a little bit about how our payment system works and how that systematic devaluing of gynecologic care has really significant impacts for how the hospital treats GYN care. What I want to do is talk to you a little bit about how that impacts access to what kind of surgeons and doctors we have in the country. Next slide. So this is a map of where residency programs exist in the US. And we have really good data that where you train is actually where you're likely to go on to practice. So if we want to know how to get more people who specialize in these types of treatment surgeries to take care of women across the country, we got to think about where they're training. So here you can see that residency programs for OBGYN are really concentrated in certain parts of the country. We've got California and then the East Coast, and then there's huge sections of the middle of the country that have 1 or 2 training programs in OBGYN or some that have none. So they're really graduating between 6 and 12 residents per year that are going to go on to practice in that region. So we're already seeing it kind of set up. There's huge spaces where patients are not going to have access to gynecologic care. Next slide. And what kind of skill set do our residents have when they finish their 4-year OBGYN training? Now, this is a survey that asked residents in their last year right before graduation how comfortable they felt with GYN surgery. And the results were pretty shocking. Only 50% of OBGYN graduates said that they were prepared to complete a complex surgery, not a routine small uterus, but a larger size, something a little bit more complex. So when they finished their training, they were extremely well trained in obstetrics, and they're really comfortable with routine gynecology, but not really comfortable with complex gynecology. On average, they're completing probably 2, 3, sometimes 4 times as many procedures for obstetrics, like a C-section, than they are for hysterectomy. So not surprising that they feel really different comfort levels with gynecologic surgery. All right, next slide. Now, this paper really, really shocked me. Now, when our residents say they only 50% of them are complex GYN surgery, they actually are overestimating their skill set. When residents who wanted to subspecialize in a GYN surgery specialty and went on to do fellowship, when their program directors in their first year of fellowship evaluated their skill sets, they actually rated it even lower. They said only 20 to 40% of OBGYN graduates who were pursuing additional surgical training in a GYN subspecialty could perform a key range of routine GYN procedures. So when an objective observer was viewing their skill set, they said that it was actually even lower. All right, next slide. So what impact does that have on us? When general OBGYNs are going out into practice after finishing a 4-year OBGYN training, the vast majority of them are low volume surgeons. 80% of all gynecologic surgeons in the country are low volume, meaning they perform less than 1 hysterectomy per month. High volume surgeons, those that go on to do additional surgical training, are doing several surgeries per month like this. They have better outcomes, they have less invasive routes of surgery, they have shorter operative times, they have lower procedure costs. And so that is a big impact on what patients get and the quality of care they receive. All right, next slide. This paper really, really hammers home that point. Compared to low volume surgeons, high volume surgeons had a 3-time lower risk of complications. That means those low volume surgeons 3 times more likely to have poor outcomes for their patients getting surgery. So we have this setup where we don't train enough people in OBGYN. We don't incentivize it as well. The people who go out into training are not comfortable with the complex stuff. And the practice that they do have is not as safe as people who are subspecialists. Now, I started with a map. I'm going to kind of end this section with a map. This is a map of all of the people in the country who have gone on to finish a fellowship in GYN surgery. And so it tells us these are the people who are comfortable with complex hysterectomy, taking care of patients with complex comorbidities, doing those endo excisions. This is where they are in the country. Now, this is the distance on this map that you would have to drive in order to see that specialist. So you can see in some areas of the country, you can drive 1 to 2 hours to see a provider. In New York, along the East Coast, in California, you're driving under an hour to see a specialist in GYN surgery. And then across the Mountain West, you're driving several hours to see somebody who's an expert in GYN surgery, which is something that affects half of people in this country, right? So this is how hard it is to see a specialist with the system that we have now who's comfortable and competent and going to give you the best outcome. Okay, I'm going to hand it over to my next teammate.
Well, thank you, Dr. McClurg. My name is Christopher Robertson. There's one thing different about me than all the other speakers. I'm the first to not be a patient or a provider of healthcare. I am a law professor at Boston University, and I learned about this whole situation from Dr. King, and I've learned so much more from the other people you've heard from, and I've just continued to be sort of stunned that this is even possible in 2026 to continue happening. And so I'm going to talk a little bit about how to move forward, what we can do to solve it. And next slide, please. So CMS has complete discretion here to just do this tomorrow to remove sex-based codes. The example Dr. Fitzgerald gave earlier, the biopsy on the vagina, the biopsy on the penis, there's two separate codes for that. The penis biopsy is reimbursed a lot more, but there's no reason to have two separate codes. Some of them can just be eliminated and have a single code for the same procedure, regardless of the patient. We can also, when there are special codes like a hysterectomy that are only performed on people with female anatomy, we need to revalue those to make sure they're paid fairly, and we need to use objective measures on how to value them. And I'll talk a little bit more about how to do that. But one thing that's got to be in the back of people's mind already, like, how is this even legal at all to be discriminating on the basis of patient sex? And based on my analysis with Dr. King, it is absolutely unconstitutional for the federal government to be doing this. But there are some barriers to the courts, not just there are barriers about whether the courts will take up these sorts of cases. There's standing barriers. There's some technical statutory problems because Congress has tried to insulate some of these issues from review. But there is a pathway there, and we're currently looking for potential plaintiffs to bring that suit. In addition, as part of the Affordable Care Act, there's a specific statutory provision, Section 1557, that prohibits discrimination on the basis of sex in any federally funded healthcare program. So that's a second way. This is probably already illegal, but it's easier said than done to just wave a magic wand and fix that. There's lots of barriers to getting that fixed, or frankly, we would have already done it 20 years ago. But I don't want you to lose the core insight that this violates the fundamental principles that Congress has already specified. So now let me dig in a little deeper on the next slide. Just remember that Relative Update Committee of the AMA is really just a private club. It's set up by the AMA. It is not a federal advisory committee, according to the executive. It doesn't have any delegated authority, which would probably be unconstitutional if it did receive delegated authority. So CMS can fix this tomorrow. And as I said, we need to remove sex-based codes and reset female codes. I think if we go one level deeper, we need to look at the structure of this. Why has the AMA created these disparities over time and reinforced them and really been in denial about them, just refusing to admit that this is a problem? And I think they've really lost their mandate to do that work, and they should probably be replaced by a special commission, because we can give you, we've already talked about, 20 or so specific codes that are the most problematic. But as you go deeper into these 13,000 codes, there's more work to do. More specifically, this is a congressional briefing. Thank you for those of you that are staffers or interns. Thanks to the members of Congress that opened this up. There are some specific things to be done. And the most important is on the next slide. But before we get there, I think Congress can do several things around requiring CMS to do this work, since the CMS hasn't done it themselves. But let's go on to that next slide, because we have the appropriations language that we've actually brought forward for fiscal year 2027. Like any legislative language, the font is small, the text is technical, but the concept is pretty straightforward. CMS, if you'll just join me at the last half of that highlighted section, CMS has to apply the current RVU rates for male-specific procedures to those equivalent female specific procedures, and establish a distinct code for endometriosis excision. It's just, we haven't gone enough into the details of why we need a special code there that doesn't exist, but you got that in Minna's early presentation. So this is the language we are suggesting or educating could be used to solve this problem going forward. I think I'm mostly here to answer any questions. I hope that's clear enough. I do want to have you check out surgicalparityproject.org, which just launched and we're still being revised as we speak. This is the focal point for this particular issue around women's health. There's a place there to sign up. There's a phenomenal video that our team has built. We'll be starting at some point to be able to raise a little money on that site as well to support this work. We've come a long ways just in the last, say, 18 months since we've started really trying to focus on these issues. We've built this phenomenal team you see here, and I'm just feel fortunate to be part of it. Check out that video at the QR code, which you can also reach at surgicalparityproject.org. And I think we're now ready for closing comments by Liz and Q&A.
Liz, I think
Might help if I took my sound, turn the sound on. Sorry. Thank you so much, all our speakers, phenomenal insights. We do have time for questions. So we'll take those in the Q&A box, which I'm trying to look at here. Before we jump in, why don't we just start off with, so we have mostly physicians, we have patient advocate, and then we have a lawyer. We actually have two lawyers because Louise wears two hats. But I think what's really important is to condense it down into what the congressional staffers can do with this information. So I think Chris closed out in a nice way to summarize it, but I think it would be really helpful to say why this FY27 appropriations report language is so important to starting to equalize these codes. And I'd love to pass to Jocelyn because you had worked a lot on this language, just to really summarize why in particular this language this year in this appropriations process is super important.
Yeah, well, I am a surgeon and not so much a policy wonk, but I can't emphasize enough that equalizing this is going to allow not only expansion of GYN surgical services, but this also brings all women's health services kind of along with it because OB and GYN are still very linked. And so not only, I know that as GYN surgeons, we are getting really not a lot of representation on the RUC, but we also are very cognizant of the fact that there are maternal health deserts as well that are going hand in hand with the way that the system is currently set up to devalue all of us. So I think bringing this example of how urologic procedures, male procedures and female procedures that we can point to and say are really equivalent, but and they're honestly just as costly to perform, so that we are paying for them on the back end. They cost just as much, they just don't reimburse as much. And it's leading to this real downshift in our valuation. So I think the language around that type of equivalency cannot be emphasized enough. Hopefully that answers the question.
Yeah, that's great. Thank you for that. And Christopher, as our lawyer here, we have a question about what do you need to be a plaintiff in this lawsuit that you're working on as far as discrimination?
Yeah, we need both named patients. So if a patient does want to stand up, I think that'll be a powerful piece of litigation. And probably in practical terms, more importantly, to have someone who actually bills CMS for this sort of care. So whether it's a surgical practice group or a healthcare system or an individual hospital, it gets a little technical as who's actually sending those bills, but the people that are actually harmed by this in the first instance are the physician groups that are making the billing, and it's part of this larger system, but they would be the tip of the spear.
Okay. If people want to get involved at all or share their story, do they go to surgicalparityproject.org?
That's right.
Okay. Perfect. We also have a question around profitability. So have you, or when you've presented this information around profitability to the hospitals, what is their response? Are we seeing that they are supportive? Or are they blocking? They don't want to see it? What can you share on that? Anyone?
I mean, I can just say that like it's not, for malicious reasons that they're doing this. I don't want it to be like, oh, these administrators are bad people. They have been put in a position of needing to keep the lights on in their hospital. And since, commercial insurers, like private insurers and Medicaid, Medicare alike, have adopted this payment model, in a sense, their hands are really tied. If they're self-insured, there are places that can internally adjust what they pay themselves for certain things. But most hospitals, mine is a good example, like it depends what insurance the patient shows up with, and the insurance company decides what they pay per RVU based on the negotiations that have happened. And so it's not that they think this is an okay thing to do. I'm sure they would love to change it, but they do fall back on the standard CMS has set.
And also some of the downstream effects that we associate with profitability, like me being able to get an OR for the long endo cases. Sometimes it's not necessarily administrators actively thinking we don't want to give Louise an OR, we want to give urology an OR. It's the downstream trickle of things. This is embedded into our system. A lot of people don't even realize that it's happening. They have a bigger staff because they make more money, so they can find those OR dates faster than my staff can. Like we even have ORs that are allocated fairly equitably when you look at the system for allocating those ORs, but I only have one person to find that OR and they have 10. So I'm not going to grab that OR as fast as anybody else to add my case on. So, anytime that you have systemic discrimination, a system that's been in place for a very long time, you can think of it as almost tentacles that sort of spread their way into things. We have to pull all of that back and really educate people about how this is affecting things and how we need to make really strong changes that will then trickle down and change the inherent bias that results.
That's very helpful. I'd love to turn to Dr. Brown and McClurg with some final questions, and then we're going to wrap up. So, do we get any pushback on using that word equivalent? Is it truly equivalent as you all are saying? Is there any pushback from the medical side on that?
And when you say equivalent in terms of
Equivalent procedures for male and female, even though they're different body parts. You know what I mean?
That's an interesting one. So, we believe that they are truly equivalent. I think that when you start getting into conversations where there's this culture, right, that, and I'll give you an example. I'll start with this. There's a popular saying that OBGYNs are not real surgeons. Like people will actually say that, and it becomes part of the hidden curriculum in terms of what we tell, what the trainees come in saying that. I've been on calls, like system calls, where someone says the surgeons and the OBGYNs, and it's just very confusing. And so I think that some people have a hard time accepting that the procedures are truly equivalent because they just have felt for a long time that as a urologist, for example, and I'm not picking on our urology colleagues, we have great working relationships, particularly in urogynecology. But if you've talked to some of our urology colleagues who are urogyn trained, they'll say absolutely they are equivalent because they've done both, right? And those who are not either exposed to the complexity of the surgeries that we do in OBGYN just make the sweeping assumption that, the surgery has to be somehow maybe easier because mostly women are performing these surgeries is what I think it comes down to, and just have a hard time accepting that they are.
Yeah. And then finally, Dr. McClurg, would love to get back to your map. Love the map. And, rural healthcare is a huge focus for many members of Congress and the administration. So can you just put a finer point on how this impacts rural communities?
Yeah, it has such a dramatic impact on our rural communities where patients have to travel literally 5, 6 hours in order to see somebody who can help take care of them. And we've just accepted that as normal for a really, really, really long time. And we have to say, no, it's unreasonable for women to have to wait that long and drive that far to get care that's routine, that's part of their everyday normal healthcare.
Yeah, excellent. All right. Well, thank you all for your amazing insights today. We're getting lots of questions in the chat box. Is there a grassroots movement? What can we do? You absolutely can take action. Get involved. Sign up with the parityproject.org, womenshealthadvocates.org. We have letter writing campaigns. We do Hill meetings, Hill days. We've got a big Hill day coming up on May 21st, and we will be talking about reimbursement. There's lots of ways for you to elevate this issue. What we have found is just by educating policymakers, they're won over. I mean, they just don't know. Most people just don't know. So please elevate your voice, send letters in, contact your members of Congress, post on social media, go to town halls, get involved, and make sure we keep elevating this issue. We will send a recording to all who registered. We will send these publications that we mentioned. We will send the report language, and we will make sure you are equipped to take action. Thank you so much again, and have a great day.